Kristen, can I ask a quick question?
Sure.
Do you know the process of the timeline that the recordings will be posted somewhere?
Yeah, Dina's out, so I'll just, usually she posts it to the website, but I was going to send out all the recordings to everybody. It's going to be a link with a passcode
Mhm.
until she returns. And then post it like she usually does online for all the events.
Okay, that sounds good. Thank you.
Yeah, just give me I was waiting till all the things were done, all the recordings were done.
Yeah, that makes sense. My parents just are not able to come, so I'm going to send them the
I
recording.
understand. Yeah. So I'll just send them out. So it's going to be a link with a passcode.
Okay.
And then, yeah, and that's how you would access it. And then once she returns, then she'll post them all online to where our events section is.
Okay, thank you.
You're welcome.
Oh, there's a frog.
That's what was making the noise.
Ooh, two.
How's everyone doing so far? Great. Okay. And Kyle, is Kristen going to share your slides?
I was just shooting her a message right now. Yeah, if that's okay with her, then I would definitely appreciate that.
Yes, I'll do that. And just tell me when to advance.
Of course. Thank you so much again.
Thanks. You're welcome, Kyle.
Okay, wonderful. Well, we'll begin as soon as it's 12 o'clock noon, so in 2 minutes. All right, I think we can begin. I know folks are going to be chiming in soon, but I think just given that we have 5 presenters, I want to make sure that everyone has enough time. So welcome everyone to our final session of master's essays presentations. I'm Kristen Mari and I chair the master's program, and I've been so impressed so far with learning from each of the students from their presentations. So I look forward again to this final presentation session. So a few things just to remind folks that are new that each student will present for 10 minutes and that will be followed by 5-minute Q&A. And I usually prioritize student questions first. And you can ask your question either in the chat or unmute yourself and raise your hand. So I also want to thank all of you who have been readers, secondary readers and advisors. You do an amazing, supportive and wonderful job with these students to prepare for this stage. And so I really want to thank you for all your help. And finally, I would also like to give a shout out to Kristen McCormick, who's been helping with all the logistics for each and every one of these sessions. So really appreciate your help. So on that note, I will introduce our first presenter, who is Stanzin Angmo. I know her as Angmo. Angmo graduated from Bennington College with a Bachelor of Arts in Anthropology. And the title of her presentation is called The Steel Frame of India, Training the Indian Administrative Service Officers to Strengthen the Public Health System. So Angmo, whenever you're ready, you can share your screen.
Thank you, Dr. Mari. Can you guys see my screen? Is it visible?
It's great.
Okay,
You're perfect.
okay,
Yep.
okay.
Mm-hmm.
So hello, everyone. My name is Stanzin Angmo, and today I will be presenting my master's essay titled The Steel Frame of India, Training the Indian Administrative Service Officers to Strengthen the Public Health System. So the Indian administrative officers, commonly known as IAS officers, are the topmost and most prestigious public administrative service in India. They occupy executive positions across India at every level of the government. They are assigned with primary responsibilities and authority over large populations, which makes them one of the most powerful bureaucrats in the country, therefore the steel frame. They run all the key government departments and schemes, and their functional roles depend on the type of assignment they get, which depends on their years of service. As you can see in the slide, for the first 10 initial years of their service, they're working at the district level. During that time, their major role is implementing policies and programs. And as they rise in their seniority based on their years of service, their roles are more towards policy making at the state and central government. So why do we care about them? IAS officers are a critical governing body of the country, and their decisions shape the state's capacity to respond and manage critical health challenges and emergencies. They influence framing, implementation, and evaluation of range of policies that have substantial impact on public health. However, IAS officers come from diverse backgrounds, and not every member is trained and skilled to conduct tasks specific to public health. Many are not able to ask tough public health questions, prioritize important public health areas, and approach issues from a systemic lens. There also has been not much known about IAS officers' need for training in public health. And the existing training at Lal Bahadur Shastri National Academy of Administration, commonly known as LABASNA, which is the national apex body for administrator training, doesn't include a module on public health. So for this study, my first objective was to understand their roles and responsibilities in relating to public health, more specifically in reproductive, maternal, neonatal, and child health, and managing the pandemic, and then to identify gaps in their skills and knowledge, and then lastly, to suggest a development of a customized training module focusing on public health administration. And to do that, I used a de-identified secondary data from a training needs assessment that was conducted by the School of Public Health here, WHO office in India, Ministry of Health India, and LABASNA Academy. And this training needs assessment consisted of 10 key informant interviews, 1 focus group discussion, and a short online survey. So I conducted a quantitative and qualitative analysis on this data. So moving towards the results section, I'm going to go quickly over some of the major findings of my quantitative results. So when asked if they ever received dedicated training in public health system, only 16% of the respondents said yes. And we also asked them about their interest in taking different kind of public health system strengthening course, as you can see here, from governance and health reform, life course, approach to health, and ICE officers were extremely interested in taking these courses. So shifting gears towards qualitative findings, my first theme was roles and responsibilities. So not every ICE officers get to work directly in public health throughout their careers. However, every officer find themselves administrating health policies and programs at some stage in their career, especially during their first 10 years of service. They carry and implement important programs, including but not limited to nutrition, maternal and child health, immunization, and sanitation and hygiene. They also take vital decisions to invest and allocate funding towards improving health infrastructure and initiating new projects. As you can see in the first quote here, one of the respondents introduced a policy that allowed women to get maternity leave postpartum. They are also the major leadership role in departments or districts, and they are there to coordinate systems and make sure that things run smoothly. All ICE officers emphasize that health is cross-sectional, and even if they're not directly working in the public health or a health department, their decisions still have huge impacts on public health. As you can see here in the first quote, health is cross-cutting. So even if somebody's working in energy, for example, they can still work for health by making sure it's clean energy. And this idea were exacerbated by the COVID-19 pandemic, where all ICE officers from different positions and departments were roped in and made part of the crisis management group. And second theme is gaps in their skills and knowledge. So if an ICE officer is not exposed and have experience with public health, they're less likely to prioritize it in their administration. And due to lack of training and exposure, many try to implement uniform program across the country without really paying attention to the local needs of the people and the contextual factors that affect their well-being. Many are not able to understand the terms of the policy papers or translate them properly, which leads to misguided priorities and also gaps in the implementation. And many also lack perspective to tackle issues from a systemic lens, which jeopardizes the sustainability of the programs, because of which when they're transferred from one district to another, which happens often every 2 to 3 years during their first 10 initial years of service, the whole system collapses. And my third theme is importance and demand for public health training. So ICE officers now more than ever believe that training in public health is needed, despite of what department they work under. They said it's really important to sensitize officers about what public health is all about, and they need to learn skills to use data, to understand how to assess the credibility of data, how to monitor and evaluate programs, and also to understand how the health system is organized in India and what is it that they bring to the table and how their decisions can have a substantial impact on public health outcomes. So the findings of the TNA led to 3 policy considerations. So first is training. So introducing a module on public health at Labasana Academy will really sensitize officers to public health and teach them skills that will allow them to make evidence-based decisions and tackle complex public health issues from a systemic lens. And this training, in order for this training to be sustainable and effective at a greater scale, the wider IAS policies needs to be revised as well. So officers should be able to specialize in the field of public health or any other area of interest. And the generalist nature of the IAS is constraining in terms of rising complexity in the world today and the issues that need interdisciplinary approach. So when IS officers assigned to different districts or departments or sectors, it should be based on their expertise and their interest. And lastly, postings and transfers. So IS officers are transferred frequently every 2 to 3 years, especially during the 10 years of their service. And when that happens, they are not really able to understand the local needs of the people, motivate their subordinates, or also ensure the sustainability of the program. So there should be a predetermined average of length of tenure that each officer must fulfill at each position. So this is my last slide. Reinforcing the idea of steel frame, there is a clear gap between the perceived needs for public health knowledge and skills and the actual level of training IS officers receive. There's high interest and need among the IS officers to receive training in public health. They also have significant power and ability to promote and protect public health, regardless of what department they work under. And educating and training them in public health will be an essential investment the country can make to improve its public sector's capacity and to address the longstanding issues of maternal and child mortality. So one of the strengths of this study is that it reflects the direct perspectives and experiences of IS officers. There are a couple of limitations. It's a small sample, so it doesn't really represent the whole IS population. And it's also not a theory-driven research paper. And lastly, data is limited to the interests and goals of its organization sponsors of the training needs assessment. And to quickly just, I want to first and foremost thank my first reader and mentor, Dr. Amy Choi. Without her expertise and guidance, this essay and presentation wouldn't have been possible. Also, thank you to Dr. Phil Anglovich, my advisor and second reader, for your support, and PopFem community, including my professors, peers, and coordinators, everyone for all your support. And shout out to Sarah, Mr. Greg, and Frida, who are in the audience, for your love and for supporting my education at Hopkins. Thank you for being my home away from home, as I always say. And last but not the least, thank you to my family who are watching me from India, and my amazing friends for being with me throughout this and supporting me throughout this journey. Thank you so much.
Great job, Angmo. Wonderful, wonderful. So I will take it, I will make this open for questions. So again, I would like to prioritize student questions first. But if I don't see any, I'll ask someone else. And let me open up the chat as well, so you can also ask that way. Ruby.
Angmo, great presentation. I was so happy to hear about the IAS and to learn about your project. So I wanted to ask if you can sort of explain a little bit how you came about choosing the data, and also like what guided your choosing the themes for the qualitative component of the study.
Thank you. That's a great question, Ruby. So I was actually part of the training needs assessment. I've been working with Dr. Choi for the past 2 years, and we actually conducted the interviews and focus groups and online survey together. So it was really an honor to really talk to an IS officer for the first time in my life. So I really gained a lot of interest, and I wanted to use their data. And in terms of coming up with themes, so I reviewed the data from the training needs assessment and the draft report and the interview guides, and to just look at the patterns and the main findings. And that's how I came up with the 3 different themes, because I knew what I wanted to study and dig deeper into. So it was more of a deductive approach.
And I just have one more question with that. And did you you mentioned, this was your first time working with IAS officers. Did you guys have any say in who, became IAS officers, or, were you selecting that? Not independent?
Wait, can you
Like
repeat?
how does one become an IAS
Oh,
officer?
okay.
Did you have any idea about that? And was that
Um,
independent of this project?
Yes. So it's independent of the project, but so anybody can become an IAS officer basically, but they have to pass this really competitive national exam. Like I think about maybe more than 100,000 people apply each year, and only about I think 50 to 80 people get selected. So it's very competitive. And once they pass that examination, they go through interview and then training at the Labasna Academy for 2 years. And then they enter the service. And in middle of their tenures, they have like short trainings at the middle phase and then at later stages.
Thank you so much. Thank you.
Thank you.
We have time for maybe one more question. Okay, David, I see your hand up first.
Thank you. Very educational presentation, well presented. I was curious as to how government policy and funding, both on the
David, you're breaking up a bit. I wonder if you might want to
regional level influence the ability. Oh, I'm sorry.
You're better now.
One more
Why don't
time,
you
just
go
for
ahead? You were
time.
breaking up.
Thank you. So sorry. How does the policy, politics on a national and local level influence a program like this in terms of prioritizing and following through on public health considerations?
In terms of national policies, I think so given that IAS officers are the major governing body, so and especially in the first initial years of service, they have the scope to introduce new policies, but also it really comes from the central government or the state government. I'm not sure if I understand, if I answer your question.
Well, just interested in how the public health policy is actually impacted by government policy and government funding.
I mean, I didn't really like delve into it for this specific project, but given the role of the IAS officers for this project, they have the scope to actually decide where the funding goes from that comes from the central government. For example, they have the capacity to say, put more money towards improving maternal and child health outcomes, or introduce new projects such as introducing latrines in houses to improve maternal health, or like other policies. So they are there, but like other than that, at the national level, I didn't really delve into that.
Thank you. Thank you very much.
Thank you, Professor.
Angmo, thank you so much for your wonderful presentation. Great job. All right, so our next presenter is Sylvia Choi. Sylvia attended Grove City College, and she has a bachelor's of science and majored in biology with a minor in French. So Sylvia, whenever you're ready, you are free to share your screen.
All right, can everyone see my presentation?
Yep. Mm-hmm.
All right, thank you, Dr. Mari, for the introduction, and thank you everyone for being here today. Sorry, I'm having...
You had it before. You just need to put it in presenter mode, that's all. There you go. Now you're good.
Okay, sorry about that. So my presentation today is on men's reproductive health, specifically prostate cancer in men. According to the American Cancer Society, prostate cancer is the #1 leading cancer in men and is the second leading cause of cancer death in the US, not including non-melanoma skin cancers, which are not recorded in the cancer registries. So even though the prevalence rate is high, the chance of dying from prostate cancer is generally low, as 5-year relative survival rates for prostate cancer is about 97.5%. The majority of men who are diagnosed with prostate cancer typically have a low-risk cancer, which can be managed relatively well with active surveillance. However, prostate cancer affects men disproportionately with different stages of the cancer. The localized stage is considered as a non-aggressive cancer, whereas distant stage is considered as an aggressive cancer as the cancer has metastasized outside of prostate. The 5-year relative survival rate of men with prostate cancer dramatically drops from 100% among the localized to 30.6% for the distant cancer. Although most men have non-aggressive prostate cancer, this vulnerable cohort of men with aggressive prostate cancer face significant morbidity and mortality rates from it. There is still an unclear understanding of the etiology of prostate cancer development and why some men are more likely to develop into aggressive prostate cancer. So these heterogeneities across prostate cancer patients call for a need to evaluate and characterize which men are more likely to develop aggressive prostate cancer. According to the CDC, age is the most common risk factor for prostate cancer, followed by race, African American men having a higher rate, and family history. So these are fixed factors, which is challenging to intervene from a public health point of view to target primary prevention. Here, family history has genetic risk factors, as multiple inherited risks were reported in prostate cancer families. So for this study, the germline risk genes were examined in order to identify the hereditary risk of aggressive prostate cancer. And germline risk genes are hereditary and generational, as opposed to somatic genes. So for this study, unmatched case control study was conducted in order to understand which hereditary risk is most likely to harbor developing aggressive prostate cancer. It was necessary to compare aggressive prostate cancer patients to non-aggressive prostate cancer patients. For that reason, the control group was selected as non-aggressive prostate cancer patients rather than the general population. So all study subjects were enrolled in the IPCG study at Johns Hopkins Brady Urological Institute. Men who are diagnosed with prostate cancer were enrolled in the study, as well as some of their family members. And all participants provided written consent, and their saliva or blood or tissue samples were collected for sequencing. The study protocol was approved by the Johns Hopkins Medicine IRB. So here's the flow chart diagram of study participants. Total 1984 samples were successfully sequenced from both male and female subjects. And although family members were also enrolled in the study, men without prostate cancer and women were excluded from the analysis. And the remaining 493 men with aggressive prostate cancer were compared to 1174 men with non-aggressive prostate cancer. So for the study methods, I used logistic regression to estimate the odds ratio of aggressive prostate cancer along with corresponding 95% confidence intervals and p-value, and to investigate whether age at diagnosis and race and ethnicity are confounded. Their adjusted odds ratios and p-values were measured. And then subgroup analysis were performed in order to investigate the association for each mutation gene by two-tailed Fisher's exact test for p-values. And then p-values were further adjusted with Benjamini-Hoxberg methods. So all statistical analysis were performed using R software. After sequencing samples, 18 pathogenic or likely pathogenic mutation genes were identified in participants. Out of the 493 aggressive prostate cancer patients, 66 patients were found to have any of these mutation genes, compared to 52 patients among 1174 non-aggressive prostate cancer patients. And 18 genes were found to be significantly associated with having aggressive prostate cancer, with OR of 3.34 and p-value less than 0.05. And the results were still significant after adjusting for age at diagnosis and race ethnicity, as their AURs are very similar to the crude OR. And here it shows the proportion of the identified 18 variants shared between aggressive and non-aggressive prostate cancer groups. Of the 66 men in the case group, 5 men carried 2 distinct genes, adding up to 71 shown on the left. And similarly, 2 men carried 2 distinct genes in the control group. And we found that BRCA2 gene was found to be the most carried gene in the case group, shown in red here. And HOXB13 was the most carried in the control group, shown in blue. The second most carried gene in the case group was CHEK2, whereas BRCA2 was second most carried gene among control group. And subgroup analysis were performed by a two-tailed Fisher exact test among 18 identified mutation genes and found that 4 of them, BRCA2, CHEK2, ATM, and MBN, were significantly associated with developing aggressive prostate cancer with p-values less than 0.05. But given the rarity of some variants and the wide range of confidence intervals, p-values were adjusted to test for false discovery rates. And those 4 genes were still significantly associated with p-adjust values less than 0.05. The study design could be considered as both strengths and limitation of the study. Since there were no cancer-free participants included for analysis, this limits the generalizability of the study, but the results were able to differentiate the risk of aggressive prostate cancer among patients, which was the objective of the study. And one limitation of the study was that the participants were enrolled in the study alongside with family members. So there may be potential confounding familiar effects for comparing family members, which were not controlled for in this study. Another limitation of this study is that the study population was dominantly white, so may be limited in its ability to generalize the findings to other ethnic groups. As mentioned earlier, being an African-American man is associated with increased risk of prostate cancer. Larger sample sizes for other variants may provide more statistical significance of the results that were not able to be tested statistically. There are some considerations and next steps that I would like to highlight. The negative impact of prostate cancer is not only tied to the individual, but impacts the family as well. Other family members are at risk of inheriting the mutation gene that are related to other diseases as well. For example, BRCA1 and 2 are also the most common hereditary mutation genes associated with breast cancer in women. Also, it is important to highlight that it's hard to draw causal inferences only based on genetic components when it comes to understanding cancer. Other factors must be also considered, such as epigenetics and environmental components. For next steps, characterizing which men are more likely to develop aggressive prostate cancer is critical to develop better prevention and treatment methods, as well as preventing overtreatment for those with non-aggressive prostate cancer. So this study supports the importance of germline testing in understanding hereditary risk in addition to existing screening tests, and should also identify who and when this screening is needed. And finally, I would like to acknowledge and thank my wonderful PIs, Dr. Isaacs and Dr. Walsh, my advisor and reader, Dr. Liu, my family and friends who are always there for me, and the PFM department. Thank you very much.
Great job, Sylvia. Really, really interesting. So let's open it up for questions. Grace, let me open up my chat because I see you have a question. Grace is asking, what were some challenges working with this research?
Yeah, that's a good question. So working with large size of sample, it was pretty challenging to like synthesize and analyze just to make sure that the results are correct, and double checking, triple checking with that. And I learned a lot using R for this paper, and yeah, it was challenging, but a lot of learning process. Yeah.
Great. Other questions? Teresa.
Great presentation. I was wondering, how did you, or how did the investigators select which genes you looked for?
So that's a very good question. There's this database called GenomeD and also CleanBar, which is like global database where many researchers report their study findings with potentially risk predisposing genes related to prostate cancer. And there's a general consensus of which genes are highly risk, have higher risk of developing prostate cancer. And so we sequenced every samples, and then we found those 18 genes that are also associated, like compared to this database findings. Yeah.
Mm-hmm. Great. I have a quick question. Well, maybe it's not quick, but I'm just wondering, how does your findings compare with other studies that have been done on this in terms of gene research?
Yeah, so a lot of hereditary cancer, prostate cancer research conducts some similar design of the study. They mostly do case study, which might not be that familiar for many people, but they compare like how I approach in the study among the prostate cancer patients instead of general population who don't have prostate cancer, just to really characterize and distinguish the risk factors for aggressive prostate cancer. Yeah.
Mm-hmm. Okay, great. Well, thank you so much, Sylvia. This is a great job. Wonderful.
Thank you.
Okay, so our third presenter is Chanel Lee, and Chanel graduated from Johns Hopkins with a Bachelor of Science degree. She majored in neuroscience and French, and the title of their presentation is Assessing Teachers' Experiences in Implementing Trauma-Informed Approaches in School-Based Sex Education in Baltimore City, a Qualitative Analysis. So Chanel, whenever you're ready, you can go ahead and share your screen. All right.
Do you see it?
Yep, you're great.
Perfect. All right, so today I will be talking about teachers' experiences in implementing trauma-informed sex ed in Baltimore City Public Schools. Youth trauma is a major public health issue affecting nearly 2/3 of Americans. Traumatic experiences during childhood are commonly measured as adverse childhood experiences, or ACEs, which include physical, sexual, and psychological abuse, exposure to domestic violence, living with individuals who have mental illness or have been incarcerated. Trauma is associated with a wide range of physical, mental, and emotional health outcomes. This includes sexual risk behaviors and sexual health outcomes such as teen pregnancy, STIs, and sexual violence. It's also important to recognize that some of these sexual risk behaviors can serve as coping mechanisms. Despite the evidence of trauma affecting youth sexual health outcomes, there is little effort to formally codify and integrate trauma-informed practices within sex ed. Now, sex ed is highly important, but certain topics can be traumatizing for youth, including less heavy topics such as body anatomy, family dynamics, and contraception, to more heavy ones such as sexual assault and dating violence. So trauma can be a barrier preventing youth from accessing sex ed and adopting safe sex practices, which undercuts the effectiveness of sex education. So I've been talking a lot about trauma-informed approaches, but what does that mean? The term trauma-informed was first developed by researchers Harris and Fallot, who described a trauma-informed approach as one that knows the history of past and current abuse in an individual, and second, understands the role that violence and victimization play in the lives of trauma-affected individuals. An important reason why we are studying trauma-informed approaches within sex ed is because they're not as well characterized in the literature compared to more general trauma-informed practices within the classroom, suggesting that there is a knowledge gap. In the context of sexual health and education, there is an existing framework available put out by an organization called Cardea Services, which is based on 6 key principles: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. Our codebook is adapted from Cardea's Guide to Trauma-Informed Sex Education. The aim of this study was to understand teachers' perceptions of trauma-informed approaches during sex education and to document their challenges in implementing such approaches. The added value of this study is that it advances our understanding of trauma-informed sex ed practices within a public school system. For data collection, we conducted 8 focus group discussions with 23 K-12 health educators in Baltimore City Public Schools over Zoom. We see that most participants work in middle and high schools, and the majority are physical education teachers. For analysis, a deductive thematic analysis was used to code and analyze the transcripts based on Cardea's framework, and the quotes were pulled and organized into matrices. 2 additional codes were created to identify teachers' responses to the direct question about trauma-informed practices that they implement in the classroom and to identify their challenges in implementing such approaches. For results overall, teachers demonstrated knowledge and awareness of the role of trauma in young people's lives and of strategies to address trauma in the classroom and the broader school setting. Our findings showed that when teachers were asked about trauma-informed practices that they implement in their classrooms, their responses mainly centered on 3 themes: safety, trustworthiness, and transparency. So now I'm going to go through quotes that illustrate each of these themes in detail. Creating an emotionally safe classroom environment was an important priority voiced by all participants. Teachers described building emotional safety in the classroom by 2 main strategies: being available for one-on-one conversations with students and verbally reminding students that the classroom is a safe space. For example, one high school teacher said, "I mean, just having like more one-on-one conversations or like staying after class, like still in the Zoom, whether you're saying like providing a safe space, like I always say this is a safe space." At the same time, however, creating safe spaces was particularly difficult during virtual and hybrid learning due to technical and privacy issues. One high school teacher said, for some kids, it was really hard to they don't necessarily have their own room or, connectivity, like connection issues might be a thing, or like you said, they were sharing computers, or, their parents are also working from home. Fostering trustworthiness in the classroom was also discussed by teachers. Teachers expressed trustworthiness through their preparedness and willingness to offer support to students who might be impacted by certain challenges in the household. For example, one elementary school teacher said, "I'm very sensitive to some of the things that are going on in the kids' lives. Like I know I've had kids that have parents that are incarcerated or things are going on at home. And so I try to be, sensitive and open to talk to them if they ever want to talk to me, that kind of thing. Try to build relationship with them and get to know them, get to know if they're having a problem at home or, something's going on and talk to them about it. Let them know that I'm there for them, basically." Another high school teacher also reported using on-site school staff to support students with traumatic experiences and making students aware of those resources. We have one high school teacher saying, also, like I said, utilizing our social worker, we have a part-time school psychologist. So making sure that those people were readily available and encouraging them. They always had office hours. So I guess, just creating a safe space for them to know that there's no judgment, it's all going to be fine. Lastly, teachers described being transparent with students. Teachers exhibited transparency by giving students notice of challenging content in advance of the lesson, validating student feelings and experiences with respect to their trauma, and reassuring students that they are supported. We have one teacher who said, "I realize that literally everything I talk about has some form of trigger. Mental health, tons of stuff. Talking about consent and boundaries has rape and assault and stuff like that in it. Even nutrition has mental health issues with eating disorders. So it's just, and substance abuse. It just brings so much traumatic experiences that could happen. So I always start off by saying this class is all about you. And sometimes the things we talk about are really hard." So in this quote, we really see how it's not just sex education, but really the entire health education curriculum that can be triggering for youth. So we see how school-based curricula can serve to sometimes re-traumatize youth and how students and teachers alike need to be aware of these potential triggers. The findings reveal teachers' perceptions and understandings of trauma-informed approaches when they are directly asked about implementing such approaches in the classroom. Teachers are aware that traumatic experiences can affect youth and that there are appropriate ways to respond to them in the classroom. The responses also highlight a need to provide teachers with greater guidance on how to address trauma in the classroom. Teachers' responses touched on 2 or 3 domains of the CARDEA guide, but other aspects of the framework were not discussed, which suggests that there is a need to provide more professional development support for teachers to strengthen these areas. There are a few limitations of our study. Our primary limitation is the way we ask teachers about their implementation experiences. Instead of asking teachers how they create a safe emotional space or how they prepare for trauma responses from students, we ask teachers a general question about how they integrate a trauma-informed approach in the classroom and coded their responses based on our codebook. Speaking of our codebook, one limitation is that it does not contain an exhaustive list of trauma-informed practices, so other strategies used by teachers to address trauma in the classroom might not have been accounted for by this data. Since teachers self-reported their experiences, there's also some social desirability bias at play. Our studies also focused on a specific group of Baltimore City public school teachers, so generalizability is limited in that sense. COVID-19 is another limitation. Virtual learning might have changed how teachers would have implemented trauma-informed practices in person. In addition, COVID-19 affected data collection because all the FGDs were conducted over Zoom and not in person, and people tend to be less responsive over Zoom. Altogether, a trauma-informed sex education may constitute a better instructional fit for youth who experience trauma and whose needs are ultimately shaped by trauma. Future avenues of research should work to compare teachers' self-reported implementation practices with their actual observed practices in the classroom, explore trauma-affected students' experiences with and attitudes toward trauma-informed practices, assess the large-scale safety, feasibility, and effectiveness of trauma-informed approaches during sex ed, and disseminate standardized guidance for delivering trauma-informed sex ed for educators. Here are my references, and I would like to thank firstly, Dr. Mari, my first reader and advisor, Dr. Marshall, my second reader, for all their support and guidance. I would like to thank the entire OPA evaluation team, especially Annie Smith, whose support has been really integral to my success, the cohort, my family, and my cat Treasure. Thank you.
I love these cat pictures and dog pictures. Great job, Chanel. That was wonderful. So I will open it up to Q&A. Let me get my chat box open. Okay. So questions. No questions? Okay, David, thank you. All right. David, go ahead.
Thank you. Most interesting. I was interested in the issue of transgender and gender identity issues and how they were handled or discussed as a growing crisis, I think, within the adolescent community.
Yeah, that's definitely an important area for educators. And that was a topic that did come up during our focus group discussions. And so teachers, if I remember correctly, they did talk about wanting more support and guidance around discussing gender and sexuality for students in the classroom who might be going through certain circumstances related to gender and sexuality. And so there definitely is a need to have more inclusive teaching practices within the classroom. That answers your question.
Thank you. One other issue, and that is if the teachers were to reveal some critical problem in terms of mental health or social behavior, how did they view their responsibility in reporting this to either parent or authorities?
Yeah, that's a great question. I did talk about this in my essay. And most of the participants, when a student would disclose a traumatic experience with them, they would work with them one-on-one, and they would also recruit, not only get their parents involved, but also recruit various school staff, such as counselors, psychologists, social workers in the school system to help support students with those traumatic or mental health experiences.
Thank you.
Any other questions? Well, Chanel, I know your essay, but I'll just ask, maybe just, can you tell us, what was the most surprising that you found from your research?
It's interesting. Some teachers would say that they didn't really know what a trauma-informed approach was, but when they were describing their experiences, they were all trauma-informed practices and approaches. So even if teachers don't know, what it, if they're doing is exactly trauma-informed, it is once they start explaining. And so I think it goes to show that I think educators are more knowledgeable on what they, perceive to be.
So they know more than they think they know, maybe, huh? Yeah. Great. Well, thank you so much, Chanel. Wonderful job. All right, so our next presenter is also going to be presenting a qualitative analysis on sex ed in schools, but a slightly different take. So Kyle Oliver graduated from Rollins College with a Bachelor of Science degree, and his major was in international business with a minor in global health. And as you can see here, the title of his presentation is a qualitative analysis of health teachers' experiences with and perceptions of condom programming in schools. So welcome, Kyle.
Hello, thank you so much for the introduction, and thank you so much, Kristen, for running my slides for me. I appreciate it. Also, great job, Chanel. So today I'll be sharing a qualitative analysis of health teachers' experiences with condom programming in Baltimore City schools. Next slide, please. So in the United States, Maryland, and Baltimore, adolescent birth rates, adolescent birth rates have decreased over the last 3 decades. This decrease is partially attributed to increase in contraception use among adolescents during this period. However, as contraception use has increased among adolescents, condom use has decreased. This decrease in condom use has coincided with an increase in STIs among Baltimore youth. Baltimore City has case rates of chlamydia, gonorrhea, and syphilis over 2, 3, and nearly 4 times higher than the state average. In 2019, over 60% of new chlamydia infections were attributed to adolescents, specifically adolescent women, seen on the graph to the right. Notably, there are disparities in adolescent birth rates and STI rates that impact lower income communities of color disproportionately. This is largely due to systemic racism, classism that create barriers to access to health services, education, and economic employment opportunities. Next slide. Aside from abstinence, condom use is one of the only methods to prevent the transmission of STIs during sexual activity. As young people enter adolescence and become sexually active, learning how to use a condom is a crucial skill. A study published in 2020 cites high frequency of user error during condom use as a source of condom failure among adolescents. Adolescents who experienced user error reported a decrease in likelihood for using condoms in the future. Multiple studies found that condom programming that uses repetition, demonstration, and practice as methods of education increased knowledge among students the greatest. So the rising trends in STIs coupled with decreasing condom use among adolescents in Baltimore City emphasize the need for comprehensive sex education that includes condom programming and demonstration. Next slide, please. In 2015, with support from Federal Teen Pregnancy Prevention Program, Baltimore City launched a multi-component citywide initiative under the brand name You Choose Baltimore. A key component of You Choose has been the institutionalization of comprehensive sex ed into middle and high school students, middle and high school health classes by building teachers' capacity to implement sex ed. Given the decreasing trend in condom use in Baltimore City, the objective of this research project was to understand Baltimore City health teachers' experiences while implementing condom programming as a component of that comprehensive sex education. Next slide. So this qualitative analysis was the result of nearly 24 focus group discussions with health teachers in Baltimore City. Transcripts were coded through a combination of inductive and deductive analyses, and codes regarding condom programming experiences, challenges, and strategies were then used to create a matrix and matrices to conduct our qualitative analysis. Next slide, please. The following sections highlight the results of the qualitative analysis. Quotes from health teachers were assigned to 2 overarching categories: strategies and external factors. Responses that fall into the strategy category deal with the decision to implement or not, and include chosen methods of implementation given perceived challenges. Responses categorized into the external factors include some of those experienced challenges regarding implementation. Next slide, please. So respondents shared with us their decision to implement condom programming and demonstrations or not. These 2 health teachers shared the following. This high school teacher states, "I did not do the demonstration at all. It's just a can of worms I'm not willing to open." Another high school teacher stated, "That is really a place where it, being the condom demonstration, does kind of cross my comfort zone. I've never really done it. I'm okay with talking about it. I'm okay with the condom steps and all that stuff." Next slide, please. This high school teacher states, "Due to the fact that I didn't know who was in the environment, I didn't implement it, being the condom demonstration, at all. I was definitely afraid to. And even sometimes, depending on how my meeting went at the beginning of the year with my parents, where I actually let them know what we're teaching, depending on the pushback I receive from the parents, it lets me know how far I can actually go with the class. Because some years I have parents who don't want to go into that or don't want to do the demonstration. And it's kind of scary slope, because I'm like, well, is anyone going to back me up if this parent really wants to fight it? And as I said, because I'm not from the health background, it's just a little scary at times." This quote provides a lot of depth into the intersection of anxieties many health teachers expressed over implementing condom demonstrations specifically. The fear of pushback from parents and uncertainty of whether the school administrations would support health teachers that implement lessons that parents disagree with is understandably unnerving to health teachers. Next slide, please. The virtual environment created challenges for health teachers as well. This high school teacher states, "I don't think that some of my students felt 100% comfortable because they were indeed at home and they were not in the 4 walls of my classroom. So certain portions, like I said, were a little different, especially that condom demonstration. Student comfort and safety was perceived to be higher when they were in the classroom rather than online. Environmental factors such as siblings, parents may have influenced students' feelings of comfort and safety while doing the virtual learning process." Next slide, please. The following is an exchange between 2 health educators discussing challenges associated with implementation as it relates to parent influence. This first health teacher states that students are never a problem, parents are a problem. The second health teacher responds by saying they actually feel that this isn't something that should be taught in school. They should have control over when their child learns this. So challenges to implementation were found to be more associated with external factors that impacted health teachers' comfort and capability when implementing. Parent influence was commonly cited as a challenge to implementation. Next slide, please. 2 high school teachers share the following implementation strategies. This first teacher states, "For my classes, I have to do a lot of reinforcement. They say, list the steps, tell me exactly how to apply a condom. Then they unmute themselves and say, this is step 1. Then I get them to call on the next person that would do the second step, and so on and so on." The second high school teacher states, "I actually did the demonstrations. I just gave them a warning. I said, hey, we're about to do this next unit. We're going to be going over some stuff, and it's going to be awkward and weird. I gave them some warnings, and I said, try to make sure no little kids are around, because I'm going to show you some stuff." The first health teacher highlights the use of reinforcement when implementing condom step processes for classes with different learning needs. And the second health teacher is open and honest with the class that they may find the subject matter to be awkward and to make sure that they're in an environment that's conducive to discussing this sensitive subject material. Next slide, please. This high school teacher says, before you even think about doing it, being the condom demonstration, in the classroom, I always make sure that it's explicitly spelled out in the letter I sent home and had them sign at the beginning of the year. Because I got lazy on that for a few years and I paid the price for it. So when I do it now, I make sure that there is something signed off by the parent agreeing to it in advance. But it's a tough thing to do in a classroom environment. In reference to the perceived pushback from parents, many health teachers cited a need to create a letter home that would lay out the lessons covered and be signed and returned in order to protect the teacher from blowback if parents were dissatisfied with specific lessons being taught. Next slide, please. I wanted to end with this response from a middle school teacher who was excited about an idea for condom programming at their school. They say, I just had an idea, doing the small group stations, right? So you have a station with condoms and they have to find the good condom. And then another station with a privacy screen where they can be private and do their own practice putting on the condom by themselves, right? And then maybe you could break it up into like a station lesson, like a myth station, where they have to separate the myths versus facts about condoms. That could be kind of a cool self-propelling exercise. So this was categorized as external factors because of the supportive environment this teacher had with their school and their ability to create a more comprehensive condom programming lesson. This addresses the need for a functional understandings of condoms and their efficacy, reinforcement through practice, and knowledge to dispel myths that create barriers to use. Next slide, please. So in conclusion, condom programming and demonstration is necessary to address the increase in STI cases among adolescents in Baltimore City. In order to do this, teachers need to be comfortable in their ability to teach and demonstrate condom use, feel supported by their administration while implementing, and be equipped to have constructive conversations with parents and bring parents into the education process. Next slide, please. Limitations were highly reflective of the COVID-19 pandemic. Many educators had no prior experience implementing their curricula in the virtual format. This influenced the experiences and perceptions of condom programming compared to what they may have been when teaching in person. Additionally, the collection of data was limited to virtual focus group discussions, which may have impacted the quality, sincerity, and overall level of detail and responses given. Next slide, please. And thank you all, of course. Thank you first and foremost to our research team, Dr. Beth Marshall, Annie, Leanna, Chanel, thank you for all the support and encouragement. Thank you to my advisor, Dr. Jackson, for the reassurance that I will in fact make it. Of course, I have to thank my mom, dad, and brother for everything they did to get me to where I am today. Big shout out to my partner, Lulu. You were unbelievably supportive and you helped keep me motivated and optimistic through the whole thing. Last but not least, just thank you to this incredible cohort. I really could not have done it without you all. Thank you all.
Great job, Kyle. Love it. All right. So again, I will take questions either in the chat or you can unmute yourself. Emmy.
How do you think your results might have been different if we weren't in the middle of the COVID-19 pandemic? I thought actually those insights are really, really important, obviously, because teaching got harder, as we all know. But do you have any insights on what might transfer, aside from the obvious things about Zoom and people being in the room or sharing computers?
I think responses would have been less influenced by external factors. I think maybe we'd have gotten a little more insight into teachers' maybe personal discomforts as it relates to implementing. We maybe would have gotten a little bit more insight to administrative factors and support felt by teachers, like being in the actual classroom and having that kind of close contact with administrators. Yeah, very good question, though.
Well, yeah, it's I'm asking about a counterfactual, of course, but you did get quite a bit of insight on the discomfort, though, and the parents issue, which is, of course, you know.
Yes, and there's a lot more
stressful for teachers.
a lot more I wish I could have included in this 10-minute presentation that I just couldn't do it, that I discussed further in my paper. But I think that depending on how, I know schools are kind of a hotbed for COVID outbreaks at the moment, and the cases are rising every day, which is another scary component of the world we live in right now. But I know that once it's kind of deemed safe to do so, the research team is going to be doing in-person focus group discussions. So hopefully we'll learn more whenever that's allowed.
Well, terrific presentation and really interesting project. Congratulations.
Thank you so
Yeah,
much.
and it would be interesting to do those comparisons to see kind of what difference the virtual versus in-person focus group data looks like. Yeah.
Absolutely.
All right, Gretchen, I see your hand up.
Yeah, thank you so much, Kyle. That was a great presentation. And I hope that you and the rest of us in the cohort can go ahead and start doing condom demonstrations at ceremony, probably,
Yes.
since it makes others so uncomfortable. So I think we need to go ahead and put our hats in the ring for that. But on a more serious note, you mentioned that like the administrative support and parental engagement was really helpful for teachers. Do you see sort of a larger role of these interventions could play in terms of teachers navigating sort of these controversial sex ed curriculums?
Yeah, definitely. Great question. Yeah. So yeah, condoms are certainly not the only point of contention between parents and school systems, especially right now. We did hear some feedback from focus group discussions, both in the city and at the different county levels during the research project that regarding some parent dissatisfaction with other areas of education. But I think it's like really important to kind of create those channels to engage parents in the education process. It definitely could help with a number of those different areas. And like, it really just boils down to sharing information, like why is this important for their children? And then extending that olive branch for them to kind of continue that conversation at home if they want to. Obviously easier said than done, a little idealistic at times, given some of the politicized nature of certain topics. But no, forming a relationship like that between parents and schools could definitely help get around a lot of those hot button issues, including sex ed.
Mm-hmm.
Thank you.
Great.
Good question.
Thank you. All right. Any other questions? All right, Kyle, way to go. Thank you so much.
Thank you, everyone.
Fabulous job. All right. Our final presenter is now here. So Haley Thomas she came to us from Trevecca Nazarene University with the Bachelor of Science. She majored in chemistry, and the title of her presentation is called A Qualitative Exploration of Reproductive Coercion Experiences in Geo-culturally Diverse Sub-Saharan African Settings. So Haley, you can take it away whenever you're ready.
Great. Thank you for the introduction, Dr. Mari. Can everyone hear me okay?
Yep, you're good.
Okay. Let me share my screen. All right. Can everyone see this?
Yep.
Okay. So as Dr. Mari said, the title of my master's essay is A Qualitative Exploration of Reproductive Coercion Experiences in Geo-culturally Diverse Sub-Saharan African Settings. A couple of terms and definitions. First, intimate partner violence, or IPV, which is the emotional, physical, or sexual violence perpetrated by a past or present intimate partner. Reproductive coercion, or RC, which is any intentional behavior that interferes with another's reproductive health, autonomous decision-making, or pregnancy outcome. Pronatalism, which is a set of social beliefs, assumptions, and forces across different cultures that pressure people, especially women, into having children. And lastly, antinatalism. And while this has various philosophical and political definitions, for the purpose of this study, it will be the opposite of pronatalism, or pressures to discourage people from having children. Okay, so IPV is the most common form of violence against women, with 1/3 of ever married or partnered women of reproductive age globally reporting experiences of physical or sexual IPV during their lifetime. RC is a separate but often co-occurring abuse alongside physical or sexual IPV, indicating a possible link between experiences of violence and reproductive control by a partner. RC can be categorized into 3 subtypes, as seen here with the Venn diagram. Pregnancy coercion are behaviors such as threatening to leave or harm a partner if they do not get pregnant. Birth control sabotage includes behaviors such as removing, poking holes in, or breaking condoms. And abortion coercion are behaviors such as interfering with a partner's ability to seek an abortion or threatening to harm upon their refusal to have an abortion. RC data from sub-Saharan Africa remain limited, and measurement differences between contexts restrict generalized comparisons. However, among the few published studies, associations between RC and health and behavioral outcomes have been identified, like PTSD and covert contraceptive use. There are a few qualitative studies that have been done in Nairobi as well, and some identified themes are noted here. This present study uses data from Ethiopia, the Kano and Anambra states of Nigeria and Uganda, where there are few to no published studies on RC. These settings are at different stages of fertility transition and have varying prevalence of modern contraceptive use and lifetime IPV. So with previous studies indicating links between IPV, contraceptive use, and reproductive control, it is pertinent that we explore RC experiences in these settings. So the rationale for the study is based not only in the lack of data in our study sites, as previously mentioned, but also the limited existing data in sub-Saharan Africa overall. So most of the published studies have examined RC within subpopulations of women. There are no studies on RC specifically that include male perspectives, and there are no qualitative studies outside of Nairobi. So in order to better understand the context in which RC is perpetrated in diverse sub-Saharan African settings, this study aims to specifically examine the experiences of RC among both men and women in Ethiopia, the Kano and Anambra states of Nigeria, and Uganda. So data from this study come from the Women and Girls Empowerment in Sexual and Reproductive Health Study, which was a multi-country mixed method study operating under Performance Monitoring and Accountability 2020 project, which is now PMA. And it focused on sex, contraception, pregnancy, and family planning decision-making. After interview guide development, interviewer training, and pilot testing, data was collected between March and November in 2017 in the 4 sites previously mentioned. Eligible participants were identified and recruited by in-country interviewers via community-based proportive sampling. Women of reproductive age and men 18 or older were eligible to participate in either a focus group discussion or an in-depth interview. 38 focus group discussions and 120 in-depth interviews were completed across all sites. They were transcribed from the recordings and translated into English by the interview teams. A deductive code book was created from the Women and Girls Empowerment Framework with an emergent inductive themes mapped into the initial cross-site code book. The full code book was then used for coding of transcripts in the Atlas TI software, and codes were quoted as reproductive coercion if they described experiences of reproductive control. All of those previous steps were completed by the original study team, so I indicated that here in purple. So while experiences of RC were coded in the parent study, thematic analysis and matrix development were not undertaken, prompting the secondary analysis. So I used the matrix method to analyze experiences of RC that were consistent across all 4 study sites. Emergent RC themes range in severity and included indirect reproductive pressures, direct family planning interference, and concurrent physical or sexual IPV and RC. Many women reported pronatalist indirect reproductive pressures, such as social or financial sanctions. Women voiced concerns about being hated, ignored, neglected, or forced out of their home if they refused to meet their partner's pregnancy demands. One female said, "This man can hate you for good. He can even stop giving you the help he was extending to you. In case you agree, he will treat you well and handle you with care." Additionally, childbearing was seen as a marital obligation. Male partners had the power to destabilize their partner's lives by dissolving relationships or forcing them out if they refused to reproduce. So a male in Kano said, "My wife is under my care. Whatever I want, she will have to abide. The reason why I got married to her was to give birth to children for me. You will come to my house without having a child, you will go back to your parents' house." Interestingly, men and women not only reported experiences of pronatalist RC behaviors, but also antinatalist behaviors. If women continue to have children without their male partner's consent or approval, they were also subjected to sanctions. One female said, "There is a man who told his wife, 'Do not conceive again, I am tired.' The wife conceived," he said. "Now, when you conceive again, you just pack up all of your things and go away from my home." The possibility of long-term security was enough to coerce wives away from conceiving without their partner's approval. A male in Ethiopia highlighted this. "She may have gotten pregnant without his permission. If he didn't approve of the pregnancy, even after she gives birth, he may not even give her basic care because she gave birth without his consent. Since females have this fear, they leave the decision to their husbands because they will need their help later." Another theme was direct family planning interference. The pronatalist interference behavior that was mentioned across sites was condom sabotage. One female said, "You cannot take a condom for granted when you have not agreed with a man, because a man can put in a hole and deceive you and make you pregnant." Though rare, one male participant from Kano reported an antinatalist interference behavior, contraceptive deception, and he said, "I can decide to give her something without her knowledge that will stop her from conceiving until I am ready." The last theme I am presenting is concurrent forms of violence, and for the sake of time, I will only present on physical violence regarding covert contraceptive use. Both men and women reported frequent or violent arguments about family planning. Some women use contraceptives covertly, attempting to mitigate altercations. However, covert use was reported as risky as it could result in IPV either from a partner or other actors such as in-laws. One female said, "You may use contraceptives without the husband's knowledge, like me. My husband was attending a training, so I went and started using contraceptives because I had a breastfeeding baby. I made a mistake of putting the family planning card in the bag. So as he was looking for something, he read it, he quarreled, and he told me, 'It is time for you to pack up your things and go back to your home. How can you start using contraceptives in my absence and you didn't even consult me?' So this caused quarrels, we had disagreements, and his parents started mistreating me." Women's economic empowerment may facilitate covert use, given increased ability to afford contraception or travel to obtain methods. However, economic dependence was not ultimately enough to protect women from violence or intimidation upon discovery of covert contraceptive use. A male in Anambra said, "In our culture, the man decides and says what happens in the home. Even if she is the breadwinner, the man will intimidate her into accepting his own decision. So she ends up not having a decision of her own. In the case where she takes a pill and the man waits for her to be pregnant, and if it is not forthcoming, she definitely will be under serious threat from the husband. So most of the time, you find the man follows his decision with action, threats, intimidation, and the like, and the woman, not wanting to lose her husband or home, will give in to his pressures." Okay, so some strengths. This is the first study in sub-Saharan Africa to qualitatively explore RC with men's perspectives. It also provides a unique contribution because it highlights both pro-natalist and anti-natalist experiences, while previous studies have primarily focused on the former. For limitations, first, these themes were identified across all study settings. I did not further analyze data for site-specific themes, which could have provided more nuance of RC in each specific context. Next, because RC is a sensitive topic, focus group discussions may not have allowed for full transparency when sharing experiences. Also, the parent study was not aimed at examining RC, but rather issues surrounding empowerment and sexual and reproductive health more broadly, which may have impacted what participants shared. Lastly, while these findings help contextualize RC in these sites, they are not transferable. Those who self-selected into the study may be systematically different from those who did not. And lastly, a summary of my conclusions and their implications. Despite participants being from diverse settings, women and men across all 4 sites reported similar experiences of RC and abuse, which identified men as the ultimate gatekeepers of childbearing. Women's reports of RC were often based in fear of violence or sanctions, while men's were consistent with power and control. Additionally, even if women were financially empowered, they were still described as lacking power surrounding their fertility. And lastly, though I didn't have time to share this in depth, RC was perpetrated by multiple actors such as partners and parents or in-laws. These findings have implication for practice. First, they are useful for informing RC screening and response services. since reported experiences highlight concurrent types of violence, such as RC and IPV, healthcare providers should be prepared to screen and identify women experiencing any of these abuses. Providers should also be prepared to detect signs of direct or indirect contraceptive interference and offer a wide range of contraceptive options for women to choose from, especially if they want or need to use covertly. Lastly, this provides insight on opportunities for harm reduction. For example, instead of giving a woman who is experiencing RC a reminder card for her next family planning appointment, which could be found by a partner and lead to IPV, a provider could call instead. And lastly, my acknowledgements. I want to thank my first reader and field placement supervisor, Dr. Shannon Wood, and my second reader and my academic advisor, Dr. Suzanne Bell. Both of them made my 2 years incredibly wonderful, enjoyable. I grew so much. They invested in me, and I appreciate them more than I can describe. Next, the department, also the student group I was involved in, Public Health Students for Reproductive Justice. My cohort, which they're in all of these pictures, I single-handedly convinced most of them to move to Mount Vernon so we could all hang out all the time. And then family, friends, and my fiance, Dalton, who, again, I could not put his support into words.
Oh,
thank you.
Fabulous job, Haley. It was just, those quotes that you have are so powerful.
Thank you.
All right, so questions. Kelsey.
Hello, amazing job, Haley. I am so proud of you. That was such a good presentation. I am wondering if, I mean, the quotes provided so much, but did any women report pushing back against men's control of their reproduction, kind of beyond like trying to use covert methods?
Yeah, that's a really good question. I would definitely say covert use was the premier way that women sort of resisted reproductive control. Aside from that, there was only one participant who I believe was in Anambra who had a really powerful quote, and she said, "I would rather my husband leave or take another wife before I die having children." But that was not something that was seen across all sites, but there was that one instance.
Ishita asks a question in the chat. She says, "Great job, Haley. I know you didn't have time to share, but what were your findings about sexual IPV?"
Yeah, so sexual IPV was rape in what I found, and there was, for an example, there was a woman who was in Uganda, I believe, and she said that if you get married and you don't have children, the community will think that the man is docile and that this woman is eating his money without giving anything in return. And so childbearing was sort of a way to gain social status. And if the man didn't have that, the community would gossip, and it would actually pressure the man into forcing sex, so forcing a pregnancy through rape. And so that is an example of sexual IPV that we saw.
Wow. Gretchen.
Haley, you beautiful, beautiful gem. Thank you so much for such an amazing presentation on such a heavy topic and such an important topic. I was wondering if you could go a little bit further into sort of explaining the differences between direct versus indirect contraceptive interference.
Yes, so in the articles that I have read, direct contraceptive interference includes things like destroying condoms, throwing away contraceptive pill packets, or like physically taking a woman to a clinic, for example, to get her IUD removed. And then direct contraceptive interference includes like the insistence on stopping to use contraceptives, or like threatening to harm if you don't use contraceptives, or if you don't stop using contraceptives.
Wow. Okay. This was, I'm still digesting everything because it was so powerful. So thank you so much, Haley. Wonderful, wonderful job. And I want to thank everyone today. And we did it, guys. You guys did it. Everybody, if you can, let's put our emojis on and celebrate. I want to just congratulate all of you master's students, the 2022 cohort. Amazing. I'm so proud of all of you. I'm so proud. You guys started during the middle of a COVID pandemic, and here you all are. I cannot tell you how just immensely proud I am, and just you impressed us all. So thank you, thank you, thank you. I've learned so much, and I want to just everyone who's here, just welcome you again to our graduation ceremony party this Friday at noon. It's going to be outside in Hampton House. It's going to be hot but nice. So we should be out there. So again, really wonderful job, guys, everyone. Take care. Oh, and